For those of you just joining now, we are just getting into the patient activation measure description of the survey items. So the patient activation measure, again, it consists of 13 different items that consist on a Likert scale. And the overall goal of the patient activation measure is to evaluate one's likelihood of taking action on their health based upon their understanding in the care process and their knowledge, skills, and ability to actually take action on that information. The patient activation measure, again, is 13 items. For example, one of them states, when all is said and done, I am the person who is responsible for taking care of my health. So there's this statement, and then the respondent must respond whether disagree strongly, disagree, agree, or agree strongly, or you can put not applicable. Now, based upon how they answer these 13 questions, it gives them a total score of between 0 and 100, and then it classifies them into one of 4 categories that are progressive, and basically that's from basically a category of disengaged to pushing forward. Now, what they found, and this again is another demonstration or a figure that shows what the levels look like, where level 1 is the most activated and level 4 is the least. And here again, you can see Insignia is the company that has developed, markets, and sells this activation measure to healthcare organizations to administer to their patients. And you can see that level 1 is the lowest, where they're starting to take a role. These individuals do not feel confident enough to play an active role in their own health care. They are predisposed to be a passive recipient of care, and that's the lowest level. So if you, for example, on this last item, when all is said and done, I am the person who is responsible for taking care of my health. If you respond, I disagree strongly with that, or I disagree with that, then you're likely to score lower on the patient activation measure, and you might fall into starting to take a role maybe in this level 1. Level 2 is building knowledge and confidence. Level 3 is taking action. These individuals have the key facts and are beginning to take action, but may lack confidence and the skill to support their behaviors. And then level 4 is maintaining behaviors, right? That individuals have adopted new behaviors, but may not be able to maintain them in the face of stress or health crises. So, but level 4, that maintaining behaviors, is that you're taking action and you're maintaining them, but you still may be at risk, right? And you can see the distribution of where individuals in the country fall on the patient activation measure scale. About 10 to 15% are level 1. So you're talking, over 1 in 10 individuals is in that area where they don't feel confident and they're very passive in terms of taking care of their own health, where 20 to 25% of the population are level 2, 35 to 40% are level 3, and 25 to 30% of the population are in level 4. So you can see that the majority of individuals are falling right in that middle. So it's not quite a perfect distribution, but it's fairly normally distributed. What's interesting on this slide that they provided, and it's something that we've talked about at length over the course of this semester, is that those individuals who are from lower socioeconomic backgrounds, who may be more likely to be on Medicaid, for example, skew far lower in activation than their counterparts and those who are not on Medicaid, and so do those in Medicare. So those individuals who are older, who may also are lower in activation, and that may be because of their knowledge, skills, and then maybe even their abilities, but it also might be a byproduct of the culture of healthcare in terms of how they've interacted with care for a number of years. So Judith Hibbert, she is the researcher who developed the patient activation measure and has written extensively about it. She's a faculty member at the University of Oregon. She's very large into health policy and consumerism within the healthcare spectrum. And this is kind of how she describes patient activation. She, quote, "Those who are activated believe patients have important roles to play in self-managing care, collaborating with providers, and maintaining their health. They know how to manage their condition and maintain functioning and prevent health declines, and they have the skills and behavioral repertoire to manage their condition, collaborate with their health providers, maintain their health functioning, and access appropriate and high quality care." So, and I think that that's kind of the goal, if you really think about it, of what consumer informatics is supposed to be doing, right? It's supposed to be providing patients tools and resources, information to really self-manage, or be a very strong team player within the delivery system. Now, is it, I don't think that she would go so far as to say that the goal is to have patients work independently on managing their health. I don't think that's it at all. I think it's so much of our lives and so much of healthcare is delivered outside of the walls of healthcare institutions that we really need to work on making sure that patients are confident in asking good questions, confident in understanding information, confidence in taking active role in really identifying solutions in collaboration with others. So often we hear one of the biggest challenges is, how do you even get questions to be engaged enough to ask appropriate questions? And that's really where informatics can come into, is how can you develop solutions, technology or otherwise. It could be education, it could be workflows that really facilitate better communication and decision-making between patients and providers, patients and staff. And that's the infrastructure that I'm interested in promoting in my role. And I believe that's what is driving some of the research around patient activation. So there's a ton of research done on this patient activation measure. And I'm sure you've seen some of this in the readings. So again, the patient activation measure works to accurately predict a patient's level of activation, which is, basically their overall level of engagement in maintaining their own health. What I found somewhat interesting, even though they've said otherwise in terms of the skewness of where Medicaid patients fall in activation, is that interestingly enough, the patient activation measure is, quote, minimally impacted by socioeconomic and demographic factors. So when you control for those factors within the modeling, it doesn't impact the results very much. It means that there's other things that are coming into play in terms of predicting that outcome. And what's coming into play those factors that are more important than socioeconomic and demographic factors are things related to willingness to participate, et cetera. Now, what this means is that the PAM score can change, right? It's not a fatalistic measure. It's not like, oh, here's an IQ score. Therefore, if we measure the PAM once, then you're likely going to have the same measure over and over and over. What this means is you can introduce some sort of a change within the system where you can educate someone or provide a different solution or have a training, and that patient can very easily move up in the patient activation measure scale. Okay. Here you can see a table from a research paper where they looked at individuals with a variety of different health statuses, and then they looked at their level of activation. Again, level 1 is the least activated patients. Level 4 is the most activated patients. And then they had some adjusted score in the far right-hand column. And so it's pretty interesting when you look through some of this data, because you can see here, again, that distribution is a little different than what was presented a few slides ago, because in that top row, we're talking about all persons with chronic conditions, right? Where the least activated is about 8.6% of the population was the least activated, and over 40% was the most activated. So that tells us that those individuals with chronic conditions who utilize healthcare more frequently are more activated than the average patient. And that seems to make sense. Then you can go down here and you can see of those individuals with specific chronic conditions, which are the most activated, which are the least activated. And you can see by the numbers here that those individuals with cancer tend to be the most activated. Those individuals with arthritis, heart disease, and depression seem to be the least activated in terms of the polar extremes anyway. You can see that those individuals who are far sicker far sicker in terms of having multiple chronic conditions are less activated than those with fewer. And that's across the board there. And those individuals who would perceive themselves as in very good or excellent health are far more activated than those who are in fair or poor health. And you can go on and look through this. But the interesting thing is that this aligns pretty well with some of the materials that we've been reviewing over the semester, where we can see the impact of some of those social determinants and other clinical factors also influence the patient activation measure. There's been some other interesting research done on, far beyond the descriptive statistics in terms of population statistics related to activation. They've also done some research to see outcomes research related to changes in the PAM scores and other outcomes. So for example, 1 percentage point increase in the PAM score results in a 2-point reduction in hospital readmission rates and a 2-point increase in medication adherence rates. So what that basically means is that if you can engage your patients in some meaningful way that actually moves the dial in terms of their, quote, patient activation, where they're, one, better understanding their role in the care process, and two, understanding how to actually take action on their health, you can actually improve clinical outcomes and decrease costs, right? You can reduce hospital readmission rates because you're probably taking better care of yourself once you're discharged, and you can actually increase medication adherence rates, which also has a byproduct of lowering readmission rates. So you can see how that, and it's interesting how this plays out in some of the research here. How powerful this patient activation measure is, and how you can tell a story with this, right? You can build buy-in within an organization, and you can clearly show the statistical relationship between promoting patient engagement, measuring some other level, some other measure related to patient engagement, and then tying it directly back to clinical outcomes that improve patient safety, decrease costs, and improve patient satisfaction. And then other research has shown that those individuals with higher patient activations are significantly more likely to engage in preventative behavior, such as regular checkups, and have a healthier diet, and less likely to engage in more risky behaviors. And like I mentioned, there's a very strong relationship to the patient activation measure and how individual patients respond to their clinical experiences. And I think this is a really interesting point, right? It seems basic, but those individuals who understand their roles more adequately in terms of their role in the care process, and also have some basic understanding of their care and what needs to happen to manage it, across the board, they are more satisfied with their care, right? That doesn't just, and that seems basic, but really think about that. People who are more knowledgeable about their condition, about their role, across the board, report better satisfaction with care, regardless of the place, right? This is a very strong statistical relationship. It's not that care is better in those places that are using the patient activation measure. It's that individuals, it's a very linear relationship. So what this means is if you're trying to improve your patient satisfaction scores for HCAHPS measures, you might want to think about a patient activation measure, and you might want to think about introducing interventions that could actually move that dial, right? Does that make sense to everybody?
Mm-hmm. Yes.
Yeah. And there's a cost relationship. Those less activated patients have significantly higher costs than more activated. And so when I mentioned that you can actually change, you can actually move the activation score for individuals, right? If you take a baseline measure of someone and then you retest them later and you retest them later after some sort of intervention, we know that there are improvements. There can be improvements in how people respond. One study found that their improvements range from 2.5 to 6.5s on the 100-point activation scale, and that concurrently with those improvements in the scale, there were corresponding improvements in a variety of health outcomes, quality of life, and a variety of clinical indicators. And I list them here. Blood pressure, adherence, different health-related behaviors, how well they participate in their care, hospital readmissions, hospital stays, etc. So, I mean, I think that this is a really, I summarized it pretty succinctly here, but there's two important points on this slide, right? One, 3 points. One, the patient activation measure is a very accurate predictor of outcomes, right? So that's one thing. Two, you can change a patient's patient activation measure through something, some intervention, some training, some education, some technology, right? You can move an individual's understanding of their role in the care process, and you can actually improve their understanding of what they need to do to manage their health, right? So you can move it. And then three, if you do move it, there's a very strong relationship to better outcomes. So if nothing else, this is a huge reason why consumer informatics should be at the forefront to complement other clinical initiatives to improve care. Some of these individuals who have been working on the PAM presented some different applications of how organizations are adopting the patient activation measure within their own organizations. And so it seems to me it's pretty basic that you would want to rapidly move into predictive modeling, right? You could see how the patient activation measure is predictive in nature. The scores on the patient activation measure are predictive of outcomes. Well, these organizations are including the patient activation measure score itself into other algorithms for modeling, for example, for stratifying populations, for population health initiatives, to understand how to allocate resources more effectively based upon clinical indicators. And so that predictive modeling area is one area. Another is segmenting those populations to allocate resources more effectively, optimize interaction methods and mediums, and then stratify interventions and education strategies. So if you're an organization and you're actually looking at doing research on a variety of different outcomes, you could actually segment the population and then evaluate whether or not those interventions are working differently in different populations based upon their level of activation, for example. So it's useful for actually differentiating groups based upon some valid and reliable measure. And obviously, you can use it in program evaluation. Program evaluation is a way to test whether or not some intervention, some program is effective at doing something. And oftentimes in programs, you're looking at a very meaningful measure that you can utilize to see if the program is working. And so a lot of organizations are using the patient activation measure as a valid measure for doing those things. Because oftentimes you're trying to test knowledge, test understanding, test engagement in many of these cases, and the patient activation measure is a good indicator of that. And then obviously you can have tailored coaching and education where obviously if you know how to predict people being into a specific group, if you are using those groups to allocate resources differently, you can do the same thing with identifying those individuals who may need more care coordination than others. If you can predict accurately that an individual is going to be in level 1 of the patient activation measure, you could probably identify those individuals who are likely needing more assistance. And so you could you could leverage your resources more effectively than some sort of a scattershot approach, right? One organization presented in this paper here that's on the screen here, how they've actually looked at using the PAM at a patient-centered medical home clinic, where if the acuity of the patient, which is on the demonstrated here on the top axis, on the top x-axis here, and then if the activation level of the patient is on the y-axis. So you can see here that a patient with low acuity and low activation level, they have them being seen by an RN, right? Whereas the medium, it might be an NP, and a high acuity, low activation is a team-based approach where it's an MD and an RN. If the activation level is a 4, which means that they're the highest level of activated patient, and they have very low acuity, they may actually employ a care facilitator or peer support for that individual, as opposed to a high cost clinician. Now, if the acuity level is high, you can see that may be different. So those individuals who have high activation and high acuity, it might be a different sort of team where you can utilize your MD resources more efficiently, right? So this is one methodology that was presented in terms of how an organization is trying to customize how care is being delivered based upon a different measure of patient need, where it's a ratio of acuity to activation, right? So it's it's kind of an interesting way of thinking about patient-centeredness in a different way, and also care coordination in a slightly more scientific way. And maybe we can come back to this in terms of our discussion. I'd like to hear your thoughts on it. Now, that individual clinic that presented this, it also had some very interesting results, right? By doing this different allocation of resources and tailoring the support or care slightly differently, they cut the ER use by nearly 50%. I think that's pretty amazing. So you can see here, this chart here. You have basically the 2008 average was the green bar. The 2009 average is the red bar. You have the count of the education urgent care ED urgent care visits in blue, and then you have during business hours, and then you have the count of ED urgent care visits in all hours. And then you can see over in 2009, we have a drastic reduction in ER urgent care visits. It says 42% in 18 months, which was statistically significant. And obviously they had improvement in 8 out of 10 of their clinical measures, had improved adherence, increased their controlled blood pressure from 56% to 76%. Their diabetes care measures were improved. 47% of their patients actually improved their PAM scores during this time as well. And then there was a 24% increase in office appointments that were actually adhered to. And then all the while, despite the change in the care process, their patient satisfaction scores also improved. So, I don't know if this is an exact answer to what ails healthcare delivery in this country, but it seems to me that it deserves some more attention based upon the outcomes that they seem to achieve. And again, this is as they continue to utilize their or allocate their resources differently based upon patient activation measure, you can see that the proportion of their population with controlled blood pressure steadily increased. Very positive relationship. So that's a little bit about the patient activation measure. And I've shared a little bit about what some of the research has demonstrated about the patient activation measure. And then I gave this little case study that was presented at HIMSS a couple of years ago that I thought was really interesting to the table as well. So I guess I want to just kind of open up to you about what you think about the patient activation measure.
I like the idea of it. I kind of wonder why, I mean, in some of the research I've done, from the library database, it seems like a lot of other countries use it. It's been translated, I think I read somewhere, into 22 different languages. Mm-hmm. So it's kind of, I don't know, I guess my question in general is why wouldn't we use it here? It's just, it seems like it's a really good idea. I mean, granted, I look at it as kind of a little different because I've gone into healthcare fields and stuff. So I've got asthma. So, I've researched it a lot, and that the table that you had with the acuity and the activation, I think for me, I have high acuity and high activation, and I actually do see a physician assistant actually. Mm-hmm. I don't have to see the regular MD anymore because as they put it, I've kind of run my own show for enough time that I know what works and what doesn't and stuff like that. So, I thought that was kind of interesting.
Yeah. Well, the thing is, I think it is being used. I mean, it's being used pretty widely in the United States.
Maybe just not here.
I some of the research, there was a really good article in the in Health Affairs, actually, one of the best healthcare journals that exists, where I believe it was at Fairview. They implemented this as a pilot project at Fairview. Fairview's integrated within their electronic health record, and they're doing some very interesting research around it. Plus, they're utilizing it there. So, I mean, I think Minnesota, and Jessica, I'm not sure where you're in Minnesota, aren't you?
Yeah, I'm in Duluth. I'm not far from you.
Yeah. You're in Duluth. So I mean, it is being used in Minnesota. I don't know if it's being used in at Essentia or at St. Luke's in Duluth, but it is being used.
I know it's not being used at Essentia because I've never had to do it.
Okay. So, but it is being used in Minnesota. And a lot of the research articles, they've partnered directly with Judith Hibbard, with Fairview, for example, to do some of these studies. So I find that somewhat promising. But the question is that why isn't there a broader uptake? And I think the question really is, I mean, if you really think about it, part of the challenge is not whether or not it's not a cure-all. I mean, what good is the patient activation measure if you don't have a strategy about how to utilize it, right?
Right.
I mean, you can come up with a predictive measure, and I think I could come up with a very good predictive measure of activation that's similar probably to predicting patients in terms of categorizing them into risky and not risky tomorrow, based upon probably 7 or 8 factors that are demographic and socioeconomic, right? So I could come up with it, but what's that next step? I mean, I think that organizations are kind of strapped financially. I
Yeah.
think we're strapped culturally, and I think you need someone with some really good vision who can put together a strategy, allocate resources effectively to actually change the paradigm in which you're practicing around a measure. Because all the patient activation measure does is gives you a score, has the potential to stratify patients in some, I would say, meaningful way. But then what do you do with it? You as an organization have to really step up and say, we're going to, for individuals who are identified in that, we're going to work with them differently. And different is sometimes perceived as dangerous.
Yeah, it
Yeah.
will change workflows. As you're saying, there has to be a strategy. It will change workflows. Clinical workflows will be affected. You need, I mean, you need so many more people than what first of all, a small organization, I don't think um, it's a good idea for them, because it involves a lot of people. You need coaching, you need social workers, you need extra nurses, you need care coordinators. We do something like a cancer, uh, just a breast center. We have a breast center, and for cancer patients, and they have so many people working over there with patients one on one, and I mean it's a lot of work. It's not easy.
Well, I mean, I think that it probably requires some more people, but it also requires you to utilize your people differently. I think
Yes,
so many
yes,
organizations don't allow their clinicians to practice at the top of their license. Um, they're oftentimes physicians that are practicing in many situations where an RN is sufficient. Not all the time, obviously, but there's a problem with this idea of letting non-physician clinicians practice at at the top of their license, really pushing that boundary. And I mean, I see that a lot with PAs and NPs and even RNs, where um, they're oftentimes being tasked to do things or not allowed to do things more accurately than maybe they should. So how do you utilize those resources you have? I mean, when do you make that decision? I think that's, and I'm not saying I have the answer. What I'm saying is that this this measure and what some of these organizations are doing gives you at least a blueprint for how you could potentially attack patients who are higher need differently. Because I think what it's saying is that the model of the primary care model of a 20-minute encounter with a physician every single time you go is not sustainable. And if that's not sustainable, then how do you approach it in a data-driven way? And does this provide at least part of a solution? I don't know. That's the way I look at it.
it has to be done in a very, very controlled manner on a very small scale first, and then kind of, scale it up.
Mm-hmm.
Because that kind of teaches you your, lessons. It gives you a learning ground. You can learn from your mistakes in a smaller set of, things that you do, and then you can scale up. If it works, scale up,
Yeah, I
um,
agree with that. That's a really good point. I mean, I think
yeah,
you should not do anything without
yeah,
piloting it. And I think that that's what a lot of this research has actually identified, is that
right,
they've done these small projects where they've piloted some things out and they've found really
right.
great results. And again, it's what I think that is so tempting with a lot of this work is to look at it like it's a panacea, that it's a cure-all, it's the solution. And this is simply just a number, you know?
Yeah.
And so you have to be very careful with that. I agree. And a patient-centered medical home is a very unique setting that has very different compliance standards than other organizations as well. They're reimbursed differently. They have some more flexibility. They have incentives for doing care coordination differently from both public and private payers. So they are afforded some different rules for approaching this as well. So I mean, keep that in mind when I presented the stuff from the patient-centered medical home. They have different, they're getting paid differently to try some of these things out.
I thought like that stage one of PAM was involving focus groups, and then in stage two they implemented psychometric like measures for scalability factors. Is that not true? Or are they still implementing those stage two?
So I think you're talking about the development of the PAM, right?
Yes.
Yeah. So when the PAM started out, they were trying to really hone in on their psychometrics with their instrument, and what they identified is that the first PAM, I want to say it was like 64 items. Is that correct? I can't remember off the top of my head, but they had a survey. It was probably 3 or 4 times as long in terms of the number of items on the questionnaire, and through their analysis, they identified that the 13 items were as accurate as the 64 items. And they used those findings in those findings. The development of the instrument was all based off that stage one where they were working off focus groups. You're right. So they used the focus groups to develop the questionnaire. The questionnaire had initially had many items, and then through all of their psychometric calibrations, they identified which factors on the PAM led to the best outcomes in the fewest number of questions. And that was what ultimately resulted, Drew, is that this 13 items is now
right.
the standard.
And I thought it was funny to read a little bit more about it, that they use the RASH psychometric methods that they still use in MCATs and PCATs and DATs to narrow down those questions for the patients.
Right.
So that was kind of interesting.
Yeah, it is. I mean, I think that I think what I think is what's the most interesting thing about it for me is that they were able to really narrow down to 13 items that are, when you read those questions, you kind of think to yourself, really? These are the 13? Because if you read some of the initial questions, they seem more apropos for the type of survey that it is. So I just find that interesting as well, is that how accurate it is given the questions that are there. You know what I mean? Because
right, for sure.
I know that doesn't sound very scientific, but it's interesting, you know. And they've tested this, they've validated it, and they've validated this instrument to other instruments related to patient engagement and clinical outcomes, and they found it very, very reliable.
Absolutely, for sure, especially in medical adherence. Like they were implementing this in HIF review in Georgia here, in some form of Medicaid program, where they're still actually not using it completely, but they were using it with like solution specialists who would be asking these questions to like a sample data worth of patients that they were given, and they were collecting this information and passing it on to, like, you know, therapists and respiratory therapists, diabetic health coaches, pharmacists, doctors, and those people would come back with diagnosis or intervention programs based on these measures.
Really interesting. Yeah, I mean that's the, and so I mean, again, it's this thing has been validated with huge populations, and then we found that it's strongly associated with, like you said, all these different outcomes. So the question then becomes, I think where we're going to start seeing more and more work coming out of, what are those interventions that are associated with the greatest jumps in patient activation? Because that's really where the money is, right? That's where where the payoff is going to be for these programs. Is that if the research has shown that there's a 2 to 7% jump in patient activation with certain interventions, well, how do you ensure that you're going to get the highest jump in activation for the amount of money that you invest in a program, right? Because to Goggins' point, we already are short-staffed, and we don't necessarily have the resources to add more. So what can we add in terms of resources or staff that is modest enough to impact the program significantly, right? That's where I imagine that's where the greatest work is going to come now in the coming years around this measure.
I think it is to educate patients. That's the key. And then also to educate them how to utilize their PHR. And sort of the marriage of PHR and EHR is very important going forward.
Yeah, I mean, I don't know. I don't know what I think that you're right. I think that it's going to be around education, and I think it's going to be around, at least initially, around kind of this patient portal thing. But the question to me is it's not about just the patient portal. It's about what do you do with it? What do you do through the portal that is going to significantly impact the activation level, right? Because I think, for example, and maybe Dhruv knows more about what was going on in Georgia, but I think, for example,
Actually, don't. I have no idea what the health professionals were doing, but kind of like my job was as a junior SQL developer. Like I was just pulling this data and providing it to some resolution specialists who would call these patients and with specific chronic diseases. And the idea behind the whole thing was to like kind of stop patients from using the emergency rooms.
Uh-huh.
So Medicaid was trying the hardest to educate them in all different facets. So would have respiratory therapists and gynos and physicians at the office level, and they would get all this data collected by the resolution specialists, and then after that, what happened, I was not sure of.
Okay. So what you're saying is that one way to educate people is to identify the ones who are at greatest risk based upon some information, maybe patient activation measure, maybe patient activation measure, and some other factor.
Yeah.
And then engage them through care coordination, right? It might be a care coordinator or patient navigator or whatever
Right.
is assigned to them to check in with them, maybe at their home or whatever.
Absolutely.
So that's one thing that you can do. I think the other things that you could do is are potentially more simple. I mean, what can you do through secure messaging where your results may actually be your reports that are provided to the individual may simply be different, presented differently, with that are more inviting to taking an active role and asking questions. I think that I think that sometimes we overthink this, where we don't seem to promote a more inviting atmosphere where people are encouraged to ask questions. Because personally, when I go into medical facility, even though I work in the field, I'm kind of nervous. And I think that the best questions that I can ask are always in written format. I find myself, I consider myself to be a decent writer, and I can write a decent question. And so my best interactions with my providers are always written. And so, Goggin talks about the patient portal or PHR. I found that to be a very engaging way for me personally to interact with medical professionals. But I would not say that those medical professionals I interact with invite me to do so. So my activation measure might be level 4. My acuity might be low, but I'm utilizing this technology in a meaningful way for me. But how do you try and change that to where the systems are designed more user friendly, and the environment in which patients, providers, and the technology find themselves actually are encouraging to using them in this format, for example. So I think there can be very expensive interventions that involve a lot of human resource in terms of people to engage folks differently, and that's one way to do it. And other is through technology, just utilizing technology slightly differently, that may require some upfront investment to ensure that they are designed properly and the workflows are tested and thought through. And I think that you probably need some balance between both extremes. Wow, sorry, I kind of got on a soapbox there for a minute. I'll get off. I will get off. So thank you all for the comments. I mean, June, any comments?
Well, I don't know. I don't want to take up too much time, but just two things I was thinking when you guys mentioned why not the broad uptake. I was working as a nurse. I stopped focusing on my studies, so I really don't know if any of the healthcare organizations, at least in the Albuquerque metro area, uses it. And I'm just wondering if another reason besides, okay, so you've got the measurement, but then, how do you use it? But would it be because there's just so many things are measured, like the meaningful use, that they're so burdened by it, and this almost seems like one more, and and I know that at least on my paper, under this new macro MACRA, I think PAM is considered part of the tool, and I'm thinking, gosh, that's a lot to measure, to report. Is it just one more thing, and yet we don't have the intervention dedicated to using that? Then I don't know. That's just one of it. It's just they're being measured to death, I guess. And my other question is.
Yeah. I think there's a lot of burden with quality measurement right now, and I think that it doesn't help that. It probably really hurt the patient activation measure that it was really starting to take off right when meaningful use was taking off, right? Because then all of a sudden, all these ECQMs started coming out, and there's probably a lot of competition for what is being taken up. I think it's a big win for them that they were written in, at least mentioned as an opportunity, right, in the MACRA.
Mm-hmm.
So I think that you're probably right with that. I mean, it is burdensome, but also, I mean, healthcare is cutting costs at every. I mean, it's expensive to purchase this as well. I mean, I was looking at including the patient activation measure as part of my doctoral dissertation, and just for a dissertation student to purchase this for one project, just for one project with one sample, I think it was about $1,000, and that wasn't a license. I mean, talking about the cost of this for a site license indefinitely. I mean, we're talking. You would really have to budget for this and make sure that you're going to utilize it meaningfully. This isn't a free measure. This is a copyrighted piece of intellectual property that you have to license. And it's not like another clinical quality measure that has been endorsed by the National Forum, Quality Forum, NQF, or IHI or whatever. So
is there an incentive involved with it in connection? I mean, we talked about meaningful use, and I'm kind of like lost. Is there like a monetary incentive involved with this one?
with this one,
With PAM?
in the MACRA there is. So MACRA is the program that basically is swallowing up meaningful use and a variety of other programs in the next stages, right? So there's it's a very, very large and complicated program that I'm still trying to wrap my mind around now. But included in there, you have to demonstrate that you're, engaging patients meaningfully. And I believe that's where the PAM, patient activation, was mentioned specifically as an option within MACRA. Now, who was talking there? I'm sorry, was that June?
This is Gagan. This is Gagan.
Okay, Gagan. Then June, were you talking about the MACRA?
Yeah, June was talking about macro, right?
Yeah, because I had found out about it through one of the research project, and I thought, oh my, okay.
Yeah. You know what? I'm going to give myself a homework item to send out a note about that. How about that?
Yeah, that would be nice.
Okay. Siwa, what about, do you have any thoughts here? Maybe she dropped. Oh, she's not. She was here a second ago. I think she knew that I was going to call on her. Just kidding. What about Noon? We're not hearing you if you're speaking. I'm sorry. Okay. Well, that's okay. I mean, if you want, you can chat it in too. But wow, it's 8 o'clock already. And I'm happy to stay on for a bit if anyone wants to. But I really like this topic. I like the patient activation measure as a topic because I think it gives a slightly, it's related but a slightly different look at ways of collecting information from patients and potentially using them in a variety of different ways. And so I think that I think the one thing that I like about this unit is that it provides students a way of thinking about this measure and thinking about how you might integrate this within some sort of a clinical workflow. So like the project with the Microsoft Health Vault, a real existing patient portal that's being adopted across the United States. If you were an organization, and you had this software, where might you place that? How might you utilize it effectively within your organization? Because there are real benefits to doing so. And I think that that's the cool thing about consumer informatics is that there are real hard benefits that can be realized if we just, take the time, do some planning, and develop a real interesting strategy. Okay, so I see we have. Okay, so and I think that's a good question. So Noon posted on the chat board. Her question was about was it patient engagement or patient activation, and I think that we need to be careful that these two are starting to be used interchangeably, which I think is incorrect. Patient engagement is around the ways in which you can interact with patients, trying to engage them in terms of their own healthcare. Activation has a somewhat different definition where it's yes, helping them to understand their condition, become more knowledgeable about their condition, about healthcare, but also measuring the likelihood that they are actually going to change their behavior. And I think that that's the difference between the two, is really hinges on that word active, because you may have interventions around engaging patients, but activation takes it to the next level, is do they work? And so related but different is what I would say. Cool. Well, once again, you've spent a lovely Wednesday evening with me. I appreciate it. I really, thanks for all the good questions here. I thought it was a nice discussion. And only one more left, less than a week away from being done with this class. So I've really enjoyed working with you all. I encourage you to really, start working hard on this final project. Please, please, please reach out to me if you have any questions. I would love to help you work through it. So with that, I will see you next week.
Thank you, Ryan.
Have a good one.
Yeah, you too.